Thank you. Good afternoon, everyone. Welcome. My name is Sonali Patel. I'm a policy advisor in the Commissioner's office here at the Administration on Children, Youth, and Families, and I'll be your moderator for this afternoon's town hall. This is a town hall which has been made possible through the logistical support of the Child Welfare Information Gateway, and we thank you for that. In the interest of time, we won't be going through introductions of those who are both here in person and who have joined us online. But we thank you very much for joining us this afternoon, and we look forward to a robust conversation once we get to the Q&A portion. In the roughly 2 years that Commissioner Samuels has been at the Administration on Children, Youth, and Families, many of you have heard him present at meetings and at conferences and on various webinars. This is the first time that our office is doing a town hall, and it's come about now during National Foster Care Month due to several factors. First, I have to acknowledge that Congress has taken some key actions in the 2 years that we've been here. Those include requirements to include screening for trauma and improvements in monitoring for psychotropic medications, as well as reauthorizing our ability to grant child welfare waivers. That's given us the opportunity to release further guidance that has been rolling out recently, which includes the recent Information Memorandum that we've released around well-being, around psychotropic medications, and around the 4E waivers, all of which will be covered throughout the presentations today. Additionally, we have a series of funding announcements that have begun rolling out and will roll out throughout the spring, which will focus on social and emotional well-being. And again, you'll have the opportunity to hear more about those in depth during today's presentations. We will, at the end of the presentations, as I mentioned, have an opportunity to have a Q&A portion. Our online participants will be able to submit questions in the chat pod, which we will capture and respond to as we get to them. And additionally, our in-person participants have note cards on their chairs. They're welcome to write questions as the presentations move forward. We'll also, during the Q&A portion, ask you to come up to the mic that's in the middle of the room to ask your question and engage in a discussion with any of our panelists. So let's go ahead and get started, given that we've gone a bit beyond the 3 o'clock mark, but I think we'll have sufficient time to get all our presentations in and to have time to have the discussions. We're going to go ahead and start off with our partners giving you all a welcome, in addition to the welcome that ACYF has just been able to give you. Our partners from the Centers for Medicaid and Medicare Services, as well as the Substance Abuse and Mental Health Services Administration, are here, and we thank them very much for joining us. They've been true partners in helping us rethink improving behavioral health for children known to child welfare, so that we can collectively work to get these children and families the right services at the right time. We'll go ahead and start off with our partners from CMS. Let me introduce Jean Close. She's the Technical Director in the Division of Benefits and Coverage at the Centers for Medicare and Medicaid Services. Welcome, Jean.
Our Deputy Administrator at CMS, as well as Barbara Edwards, our Group Director with the Disabled and Elderly Health Programs Group. We wanted to share our excitement for the demonstrations that you're going to be hearing about today. It's a great opportunity for us to share what we are doing currently in partnership with ACYF and SAMHSA. And so we're looking forward to telling you about what we're doing now and what we'd like to ask for your assistance with going forward. Joining me also on our panel is another of our partners with SAMHSA.
Hi, I'm David DeVorney from the Substance Abuse and Mental Health Services Administration. First, I have to apologize. My superior, Lark Wong, who's the Senior Advisor on Children, Youth, and Family Issues to the advisor, was pulled into a last-minute budget meeting, so you're stuck with me. But I can tell you that we're really excited about this partnership. The Administration for Children, Youth, and Families has really led and challenged us to think very specifically about the needs of children and child welfare and youth and child welfare, and specifically related to their behavioral health needs. And I think the push for a real focus on the evidence base, what works for individual youth situations, has really been refreshing, and it's been great to have that leadership to drive us in the field forward.
And at this point, we'll go ahead and begin the official portion of our presentations. So for the next approximately hour and a half or so, we'll be hearing from ACYF, CMS, and SAMHSA representatives. We're going to go ahead and start off with a presentation by Commissioner Bryan Samuels of the Administration on Children, Youth, and Families.
Great, thanks, Sonali. It's actually, really exciting to have the opportunity to discuss each of the information memorandums that have gone out over the last 4 weeks or so. We think that issues related to well-being, psychotropic medication, and the waiver opportunities themselves are really best thought about in conjunction with one another rather than seen as separate and unrelated. We think that there are critical components that the waiver allows states to be able to address that can move us forward, both in effectively using and appropriately using psychotropic medication, as well as promoting the social and emotional well-being for children who are engaged in the foster care system or who come in contact with the foster care system. So I wanted to start just briefly by introducing the basic premise around the waivers, and then really suggest to you that there's an opportunity to integrate our work. Because, again, we think that there are close ties between all of this work and a real opportunity to look at them this way. And so when you look at the waiver as an opportunity, Congress really did envision broad, meaningful change in child welfare. They specifically identified the categories that we typically think of when we think about child welfare, and really did expect significant change in one or more of these areas. So the first area that Congress indicated that the waivers were considered to address is one around increased permanency. So there will be some states that will look at the waivers and see them as an opportunity to realign their resources, both federally as well as state and locally, to address specifically permanency and increasing the rate at which children move to permanency. Other states will see the opportunity in the waivers to focus on the second dimension, which is in-home services. Some states that see a significant growth in the number of children entering through its front doors, or families entering the door, but if they could provide enter the foster care system, those states may in fact take the opportunity under waivers to focus on providing a different set of supports outside of the out-of-home care environment and really prevent breaking families apart and bringing their children into out-of-home care. And then the third category that Congress contemplated when laying out the waiver opportunity was really to look at the issues of prevention of abuse and neglect, and the prevention of children who have exited the foster care system from re-entering. Now, some states will choose to focus on one of these. States could actually choose to focus on all five. That really is up to states, but I think they will ultimately make that decision based on their current context. And given that it really is a partnership between the federal government and state government in operating the child welfare system in this country, we think it's totally and completely appropriate for states to be in the position of really making a decision about which of these areas they will focus on and which of these areas they believe they can have the greatest impact. Beyond those three categories, there's certainly lots of opportunity for states to make decisions about what the best approach is. And so what we thought we would do today is, rather than go through each of the somewhat boring details of the choices that states have, we thought that it might be more interesting for the audience for us to basically organize our presentation around what a state could do with this new authority, to really provide you a sense of the dimensions of change and the type of change that one could achieve using these demonstration waivers. So we have articulated that we think it's important for any of these waiver opportunities really to begin to address issues of well-being. Typically, in the child welfare system, we talk about safety, permanency, and well-being. States have made a lot of progress on safety and permanency. We're encouraging states to think about the next logical step in the evolution of child welfare, which is to build on the success that's been made in safety and permanency and add that third dimension of well-being. We've encouraged states to consider the social and emotional dimensions of child well-being, in large part because when we look at the literature and we look at the impact of maltreatment, abuse, and neglect on the lives of children, we see those social and emotional dimensions as being those most impacted. In addition to that, we're hopeful through these waivers that we can get really big change in child welfare. We're hoping for transformative change. We're hoping for the kind of change that can lead the field in future direction. We really want something to happen through the waivers that provides Congress a blueprint for the kind of meaningful change we need across this country in child welfare. And fourthly, we're really encouraging states to look at leveraging the involvement of other partners in their reform and transformational efforts. We know that Medicaid plays a critical role in serving children in foster care, and so we'd love to see states give consideration to the role that Medicaid might play in an overall waiver proposal. We think the work that many states have done with SAMHSA around the systems of care grants, we think that's another opportunity to really make big change. There are other federal entities that over the last couple of months have made funding announcements that specifically include the child welfare system and children served by the child welfare system, and we think other federal entities could also be brought into the fold here in looking for really transforming change in child welfare. So there are many ways that one could look at the definition of well-being. There are many ways to think about the basic components. But when you look at the level of change that has occurred in the nation, you can look at this slide here. This slide here is intended to show you just over the last 3 years how many states have had decreases in their overall population versus those states and territories that may have had increases. And as you can see from this slide, it shows you that 47 out of the 50 states plus the 2 territories, that 47 of them actually have had declines over the last 3 years. If you look at the last 15 years, you see an overall decline of about 30% nationally. And there are some states, like Illinois, like Maine and Vermont, that have had reductions in the 60 and 70%. So we think in those states that are well along the way of refining their efforts around safety and permanency, we think for those states, waivers represent an opportunity to move to that next level, which is really to focus on the well-being of children who they serve through the foster care system. In that context, what we know about serving both the children and their families is a growing awareness of where states are at and what they're capable of addressing in terms of safety, permanency, and well-being. And so we've highlighted here the two areas where you see states being in the strongest position. So as you've seen the overall decline in the population, that means their states have increased their capacity to really move children to permanency. You have also seen them able to maintain rates of safety. So even though you've seen a decline, we haven't seen an increase in terms of the rate of safety or problems with maintaining safety for children. served by the foster care system. So we think those two movements together say that many states are moving in the right direction. Beyond those two elements of well-being, we think there's more work to be done. So when you look at the impact of maltreatment on children, we know it has an impact on their self-efficacy, their belief that they're capable of doing something and doing it effectively. We know that maltreatment has an impact on their own self-image and their understanding of who they are as children and who their parents are as adults. We know that the impact of maltreatment affects an ability of a child to maintain a positive, healthy relationship both with their peers as well as with adults. And we know that maltreatment has an impact on their ability to maintain emotional regulation, to be able to calm themselves and to be able to engage in relationships that are mutually reinforcing and reciprocal in nature. And so we think that the child welfare systems in this country can begin to address elements of well-being that I just described, and to do it in a manner that begins to reposition children on a positive trajectory, even though they will spend a short period of time in child welfare. We think if we can begin to move children and their families in that direction, then when they exit the foster care system, they'll be well on the road to moving towards positive outcomes. And for those children who we choose not to bring into the foster care system, we think by addressing issues of well-being, we increase the likelihood that they won't come back to the system, that they won't re-enter the system. And so, again, we think there's an integrated opportunity here to build on what we've already accomplished in terms of safety and permanency, but use the waivers as the opportunity to turn towards really beginning to build our capacity to address issues of well-being. I've said this many times before. The progress that we've made around safety and permanency, we've made over a 15-year period of time. We don't imagine that the waivers themselves overnight will move a system to issues of well-being. We do believe that we have enough evidence and enough examples, real-life examples in child welfare today to begin that movement towards well-being and learn a ton along the way. So we didn't know in 1997 everything that we would be doing today to move children to permanency. We may not know all of the things that we'll be doing 15 years from now to move children to safety, permanency, and well-being, but we think there is ample evidence, and states have made ample progress, that this is a logical next step in child welfare, and it's one that we see the waivers as being a particularly great opportunity to move in this direction. Interpersonal trauma. It's a growing understanding in child welfare that many of the children we're serving have experienced interpersonal trauma, whether we're serving them in their homes or serving them in a foster home or living with a relative. We know more and more from the literature that maltreatment, abuse, and neglect has a fundamental and profound effect on a child's ability to function. And many in the field have come to understand it as complex trauma. Others have described it as developmental trauma. Some have described it as toxic stress. Pick whatever name you want to call it. We know it has a tremendous effect on the lives of children, and we know that it follows them long into their adulthood. And so one way to think about the waivers, one way to think about using the waivers to create a different system, a system that is transformed in its capacity to promote well-being for the children and families that it serves, we think one way of doing that would be to focus on interpersonal trauma and really to think about how from the front door to the back door, child welfare systems can use the waivers to really build that capacity. So some have wondered what exactly are the essential elements that a state might consider as it tries to build a waiver proposal around issues of interpersonal trauma. So we've put together a short list here. We have stolen this list from experts in the field. We do not claim that we're the makers of this list, but we think that the field of interpersonal interpersonal trauma has progressed to a level that we think that it is fully integratable into the work that's being done around child welfare. So some of the essential elements focus on maximizing a child's sense of safety, and that's not just physical safety, but that's psychological safety. We've learned a lot about comprehensive assessment, that knowing a child's trauma history is a critical component to serving a child well. It's also important to understand a family's exposure to interpersonal trauma, because often the parents of abused and neglected children have themselves been exposed to trauma. And so fully incorporating that in our understanding of our work with families would be important. Assisting children in reducing the overwhelming sense of emotion that they experience. Addressing issues of the impact of trauma and subsequent changes in child behavior we think are important. So do other experts. And helping children create new meaning around their trauma histories and their current experiences, all could be folded into a waiver proposal under the new authority. Above and beyond that, we think there is, let me make sure I have the right slide. Above and beyond that, we think there are a number of other really critical steps that states could take to take work that they're doing and make it really trauma informed. And so I'm going to talk a little bit about that movement. So one of the things that we think is really important as states try to build a system that makes sense. My slides are a little. So as states take the core understanding of maltreatment and really try to build a plan around it, we would suggest that one of the things that they would want to do is first really build a clear understanding throughout the system about the impact of trauma and really begin to help everybody in the system appreciate what a trauma-informed set of practices would look like. We think a second component to building a plan around interpersonal trauma is really changing the way we do assessments throughout the system. A third component would really be building a different set of case plans and doing a different form of case management in supporting children and their families. The fourth component would be to really contract for a different set of services than are currently available in a foster care system. And then fifth, to really focus on those cross-systems partnerships that have to be established, Medicaid being a good example of one, within a state to enable you to really take a child welfare system to a different level. So we would see all of these components as one that could be incorporated into a 5-year plan. Again, we encourage states as they look at each of these components to not think of the waiver as a waiver that the plan has to be implemented in year 1 and it has to be the exact same plan for all 5 years, but instead to really help states look at each of these components, lay them out in a phased approach to implementation, and to make sure that each of the components are in place at the end of the 5 years. We think that's a far more rational approach than trying to do all of this work all within the first year. So the next component that states could move to, once they have this larger strategy, is to really think about how they would train all of their staff across the system in a trauma-informed approach. And this slide here lays out the basic components of that. So building an empathetic understanding of trauma and the nature of its effect on children is critical. Raising their clinical reasoning is really important to the work that's being done here. To recognize that evidence-based practices can play a role in identifying the availability of those evidence-based practices in communities is really critical. Thinking about bringing research-friendly ideas into practice is critical. Again, because we haven't figured out all of the things we need to do to get to well-being, paying attention to the research is important, and translating some of the research into practice will be a critical component to the work. And then just making sure that families, that everybody in the system takes a strength-based approach to to working with families. We think all of those things are a part of a core training strategy around taking advantage of the waiver. Next, we would focus on some of the issues related to neglect. When you think about the child welfare system in general, you really have the families come in. It's not a great way to describe it, but we'll just keep it simple by saying that in large part you have children who enter foster care because of physical neglect as the primary reason. Some who enter because of sexual abuse as the primary reason. And then you have a very large group that enters the foster care system under the term of neglect. And so as states really sit down and try to figure out where do they target their resources, we would think in a trauma-informed approach, one area that they might focus is on the category of neglect. It's the largest category, and therefore if they can figure out how to get services and supports right there, they can have a large effect. The second reason is reflected in this slide here, which is, there was a study that was published recently that showed, as it relates to trauma, that children who come into foster care under the type of neglect category, they have the greatest rate of trauma. It doesn't suggest to you that in domestic violence there isn't trauma-related symptoms or emotional neglect or physical neglect or sexual neglect. All of those categories come with some form of trauma related to them. But when you look at the broad categories, it appears that the children who are affected by neglect also show the highest number of symptoms related to trauma. So in our thinking, taking a trauma-informed approach could focus specifically on the category of neglect and really build the state's capacity to address that issue. And again, if we can address that issue, we can get a very large bang for our buck. Next slide. Not everybody is comfortable with the idea that a family that is found to have neglected their child ought to be a candidate for being served differently or being served in a in-home setting. We think it's important for states to move in that direction. Not all families will be able to be served in-home. We think there are an increasing number of families that could be served in-home. We think that the waiver provides a unique opportunity for that. So we've provided here just what we would describe as a tiered approach to focusing on neglect, recognizing that some children and some families are more impacted. So if you took a tiered approach, you would see that from tier 4 down, you have some families that are primarily impacted in the social and environmental risk issues related to neglect. Some are also then affected at the third tier around caregiver risk, around substance abuse, domestic violence, mental health issues. In the second tier, the focus is really around families where there's a harmful child and caregiver interaction. And then in the first tier, those children that are really functioning or really struggling to function because of neglect. We would suggest that if a state was going to build a strategy around trauma, that they would start at tier 1 and begin to think about how they would serve those families in an in-home setting and then work their way down the tiers, rather than starting with those children who might be the most challenging and families that might be the most challenging in tier 1. States could really build their capacity starting at tier 4 and working their way in. Next slide. So that then provides us an opportunity to talk about, if we started there, what else could we do in a child welfare waiver to be able to address issues of trauma? We think the next opportunity is to really think about investigations in a different way. Most child welfare systems go out and do investigations. When they do those investigations, they're primarily focused on confirming whether the allegation of abuse and neglect can be documented. If they can document it, that becomes a substantiated case of abuse and neglect, and then they have to make a decision about whether a child should be removed. We think that there is a real opportunity to add a trauma focus to the investigations. We think that by doing that, it could really change the nature of the relationship with the family from day one. We think it can change the impact that we're having on the child from day one. And we have the benefit of a great example that 5 counties in California undertook to take a trauma-informed approach to investigation. We think it's got a great deal of potential, and it's one step in the context of a waiver that child welfare agencies could take to begin to move their system to a trauma-informed approach. Next slide. So for those children for which there was a determination that abuse and neglect did occur, a state could then introduce a trauma and assessment screen that would allow you to, from day one, determine whether there are trauma symptoms that are best addressed early in the life of the case. And so we're encouraging states, and one state could take the approach of first introducing a trauma screen that every child and every family with a substantiated case of abuse and neglect could be screened for to determine whether there are appropriate interventions to address their needs. For those children who appear to be struggling or families that appear to be impacted by trauma, states could go deeper in doing a trauma assessment. At that point, they would be trying to determine what would be the most appropriate means for intervening for that child or that family. And for some families, during that trauma assessment, a determination may be made that there's actually a mental health diagnosis that might be appropriate for the child or the family. And they could then go to that third level of doing that kind of mental health evaluation, which would allow them to determine whether there was a mental health diagnosis that ought to be addressed. Again, we have a good example of doing this work in states. The state of Illinois introduced a screening regimen that was directly related to this. We think that it paid great dividends in terms of the child welfare system's understanding of where families needed support and where they didn't need support, and that the trauma screen in the state of Illinois really became the starting point for the redesign of all of the services delivered within that system. And so we think a trauma screen and assessment is a logical step to take under a waiver opportunity. Next slide. Again, based on making a determination about whether abuse and neglect has occurred, as well as making a determination about whether trauma is affecting the family's ability to function, we think that one of the promising interventions is one that focuses on prevention, and that prevention is done in light of the existence of trauma for families. So there's a really promising practice around trauma-adapted family connections. It's a program that's had a preliminary evaluation and had positive results. It takes those earlier trauma elements and integrates them into a structured program of working with families. It's been shown to reduce risk factors significantly for abuse and neglect, and it represents one of the early interventions that a state could introduce to really begin to prevent families from having to be moved into out-of-home care. We think that an intervention like this could be tied to the assessment that I just described and could be tied to the results of an investigation, so that even though a family has been found in a substantiated case of neglect, a screen and assessment could be done to determine that we could serve this family in the home, providing this as an intervention. So again, it's a promising practice. It's an evidence-informed practice. It's not an evidence-based practice, but it's one that a state could consider introducing at the front end of their system to really begin to take on issues of trauma. Next slide. In addition, when we look at the past waivers one of the issues that emerges out of looking at those prior evaluations of waivers is that most of those waivers focused on systems level changes, didn't necessarily focus on building the skills and competencies of caseworkers to work in a different way with families. And so we think a solution-based casework model is very adaptable to a trauma environment. So when you look at solution-focused casework, it's defined by having a developmental focus, which we think is really critical. It has a strength-based approach that we think is really critical, and it has a collaborative approach, an interdisciplinary approach, all that could be tweaked and adjusted, but could be well integrated with a trauma agenda and really reshape the way we do casework in child welfare. Next slide. We think what's really attractive about a solution-focused approach is that it already has demonstrated to have dividends in the child welfare environment. And so as you can see from this slide here, it's been evaluated to have really meaningful changes in child welfare, and therefore we think it provides a great next step in terms of building on an evidence-based casework approach and adding to it that trauma intervention approach. Next slide. The waiver talks quite a bit about evidence-based intervention, both the waiver around well-being as well as the waiver around, the information memorandum around the waivers. And so there are a growing body of evidence-based interventions for states to choose from. Those are services that they might offer for families outside of the out-of-home care scenario, so they could provide these services in the home, but they could also deliver them in the out-of-home care environment. We've identified 5 of them that are here. We think it's interesting for states to think about these 5 because of 2 reasons. One is some of them have already been documented to have the impact that we're interested in achieving on issues of well-being. The other 2 have also been evaluated to have impacts on safety and permanency. So we think these are 5 interventions, all that have an evidence-based slant to them, each of which could be done in a trauma-based environment, and that could sync well together to really create a continuum of interventions that starts at the front door of the system, but then moves inside the system. In each of these interventions, what's exciting about them is that they're designed around a curriculum that staff in private agencies could be trained to deliver, and done in a way with high fidelity, we could rely on producing the kinds of results that we hope to get through the waivers. Next slide. We think that much of this work could be done in the context of Medicaid. This slide here shows you by age groups the percentage of children who are in the foster care system and receiving either a mental health prescription, meaning medicine, or services funded by Medicaid. So as you can see, about 36% of children 0 to 5 are receiving some services under Medicaid around mental health issues. When you look at the 6 to 11 population, it moves to over 50%. And when you look to the 12 and older population, it moves to over 60%. So Medicaid has a role. In each of the services that I described on the page above, those are serving families that would likely qualify for Medicaid services. And so we think looking at evidence-based strategies that are appropriate for children and families in foster care that all require a clinical intervention such that they would qualify under the federal definition of medical necessity. We think there's a real opportunity here to combine the two, to think about evidence-based strategies, but think about it by introducing those services that would also be supported by and subsidized by the federal program for Medicaid. So we don't just want to introduce evidence-based strategies, but we want to build them onto the existing infrastructure using the current authority under Medicaid, such that they're sustainable beyond the life of the waiver. So we think about the waiver as the transition point onto an evidence-based strategy, but it's one that we think ought to be tied to Medicaid so that they are sustainable in the long term. Next slide. We think there's also an opportunity, taking a trauma-informed approach, to rethink the way we do residential treatment in foster care also. So, you know, in most states where you have children in out-of-home care, you have somewhere in the category of 3 to 7% of them are actually in residential treatment at any point in time during the year. And so in those instances, we think that states can increase the efficacy of those treatment interventions by adding a trauma component. So this slide here describes an initiative that was undertaken back in early 2005, 2006 to introduce a trauma-based approach to a more generic approach of residential treatment. And by taking those basic principles that I described earlier in my presentation and integrating them into a residential treatment program, this collaborative was able to identify some really significant improvements in overall performance. So by combining the residential treatment with a trauma-informed approach, they were able to increase the problem reductions in those residential treatments by almost 35%. They were able to reduce the amount of time spent in residential treatment by almost 40%, and they were able to double the number of positive discharge outcomes. Said differently, they were able to double the positive outcomes that happen after a child exited residential treatment. Again, this doesn't completely dismantle the work that residential treatment programs do. It doesn't suggest that all residential treatment programs would be appropriate for a trauma-informed approach. But where appropriate, we believe that a state could integrate into the programs that it purchases around residential treatment a trauma component, and by doing so, improve performance, which means that children spend less time in residential treatment. And the benefit to the state is that they get a good outcome for the child, but more importantly, they actually achieve a savings. So combined, better outcomes and savings that states can take and reinvest, we think, is another reason why a state could take a trauma-informed approach, apply it throughout the major components of their work, including residential treatment, and collectively, done together over a 5-year period of time, could, in a meaningful way, transform the work that's being done in child welfare. And so, again, we're excited about the opportunity for waivers. We're not suggesting that everybody would take a trauma-informed approach to their waivers, but they could. And if they chose to, we've provided one pathway from where most agencies are at today and where they could be 5 years from now if they pursued a waiver. We anticipate that there will be other pathways to transformative change in child welfare that will also be proposed by states, and we welcome the opportunity to consider all of the waiver applications that really do propose meaningful change and are prepared to support states as they both propose them, refine their plans, and ultimately we're prepared to support states as they move forward in implementing a waiver demonstration project. And so this last slide here just gives you a timeline that states are on.
So as you already know, we've released the waiver. We did that last week. So states have all of the information they need to make an application for a waiver. We have requested that states that intend to apply for the first 10 waivers give us a letter of intent by June the 4th. We're not requiring that states who don't submit a letter, we don't prevent that does not prevent them from actually applying for a waiver. If there is a state that can't meet the June 4th letter of intent requirement, but can in fact prepare a proposal and submit it by July the 9th, we will consider that. We have told states that we will review all of their proposals on a rolling basis. We hope to get 10 proposals that we can work through and negotiate with states and reach an agreement by the end of the fiscal year. But here's an important point. If a state submits a plan, if that plan does not meet our timeline, but it is a viable plan, we will begin working with a state as soon as their plan is submitted. And as soon as we can work with that state to get to a place where the plan is implementable, we will do that and we will approve the plan then. So if it's the first day of the next fiscal year that we reach that agreement, that's when we will sign that agreement and that state can start then to move forward with their plan. This isn't the same as a competitive process where if you don't win the first year, then you have to reapply the second year. Instead, we'll do this on a rolling basis, and as soon as a state's plan meets the requirements laid out by Congress and is moving in the direction that we think is correct in meeting the overall set of priorities, we're prepared to work with the state to get those plans agreed upon and moving forward, because we think all states have an interest here, and we're encouraging all states to consider moving in a direction that ultimately results in them submitting a waiver plan. So again, this is one pathway, but we thought it would be valuable to think about all of the components so that as states and others consider making application, they have some concrete examples of steps that a state might take to achieve the kind of reform we'd love to see.
Thank you, Commissioner. We're now going to hear from the Deputy Commissioner at the Administration on Children, Youth, and Families, Claire Anderson, and she'll be presenting on two topics, improving management of psychotropic medications for children in foster care and upcoming funding opportunity announcements from ACYF. Thank you.
Thank you so much. As the Commissioner has laid out a vision for change and how states might go about addressing trauma for children known to child welfare and their families, an important component to consider is the use of psychotropic medications in this population. As we have an evolving understanding of trauma and the overlap with mental health symptoms, it's increasingly clear that it's really impossible to tease the two out. And so when you think about the use of psychotropic medications to address mental health diagnoses, one really has to consider the trauma that children have experienced and the symptoms that are related. And so, next slide, please. We recognize, as has Congress, that there are higher rates of psychotropic use among this population as compared to the general Medicaid child population. We see that in the literature. As you're working in states, you know that on a day-to-day basis. And as Sonali recognized at the beginning, the opening of the conversation, Congress passed the Child and Family Services Innovation Act of 2011, which provided additional authority for states to begin to think about how to oversee and monitor the use of psychotropic medications differently. We have put out an Information Memorandum, which is noted here on the slide, as well as 2 program instructions providing detailed information about the use of psychotropics and how states should begin to put together a plan in their annual state plan amendment that comes to us. And these are the 5 components. The first is a comprehensive and coordinated screening assessment and treatment planning to address the use of psychotropic medications, really to ask states to do a comprehensive screening, much like the Commissioner noted previously, and functional assessment to determine what are the needs and how are they related to the treatment that is being considered. The second is informed and shared decision-making among all of the members of the team so that there is a coordinated approach, that everyone understands what is being treated and why, and what the approach being taken will be. We want to make sure really that everyone, prescribers, caregivers, caseworkers, the child as age appropriate, are involved in that decision-making process. The third is effective medication monitoring, both at the child level and at the agency level, so that individual children are being tracked comprehensively, so that as their healthcare providers change, there is clarity about what the prescription is and why it is there, but also at the agency level, so that there's the ability at the system level to identify red flags when children are being prescribed multiple medications that may interact or may not. There may not be an evidence base for using the multiple medications. So both at the child level and at the system level. That there is expert consultation from child and adolescent psychiatry available at the system level so that states are able to make good decisions as they're tracking and monitoring, and when to go back to the original prescriber and have a conversation about why a medication is being chosen and in what constellation. And the fifth is mechanisms for information sharing more broadly and providing educational materials. So a bit of a dual process here, so that there is clarity among all team members, but also so that people are informed decision makers when they are actually being prescribed the medication. I also want to tie this back to the Commissioner's remarks about the use of evidence-based practices to promote social and emotional well-being and to address trauma, as many of those effective practices are considered first-line treatments or concurrent treatments when psychotropics are being prescribed, so that there is a psychosocial behavioral intervention being used in addition to either considering or when a prescription has been made in conjunction, so that there is a multi-pronged approach to improve functioning. Thanks, Kate. So I want to shift gears here a bit and talk a little bit about our funding announcements in our discretionary monies that we have released this year and how they relate to the overall approach to supporting and promoting social and emotional well-being and addressing trauma. We recognize that all states are not in the same place around applying for a waiver. Either developmentally they might not be ready, or it's not the right decision for their system when they assess what their strengths and needs are. And so we've tried to provide either a conjunctive or an alternative route for states to take to access resources in a way that allows them to build capacity to promote social and emotional well-being and address trauma. So you can go ahead and change slides. So I'm just going to give you a little bit of an overview of the discretionary funding announcements that we have out on the street currently or will shortly be there. This is not the full array, but I think the array that I'm going to walk through provides a really good example of how it connects to addressing trauma. So the first one is the Child Welfare Early Education Partnerships to expand protective factors for children involved in the child welfare system. And this really allows states to develop a partnership among child welfare and early childhood providers to improve health and mental health of children who are very young and need additional developmental support. We really are hoping that states are thinking about how to build protective factors for this early group of children so that we are beginning early to think about meeting their social and emotional well-being needs. The regional partnerships to expand protective factors with children with child welfare involvement. This announcement really is an enhancement of the approach that has been taken previously and really builds on the knowledge that has been gained through the work to date. We think the trauma literature really can provide an important understanding of how to address the substance use and abuse needs of parents, and that there are trauma interventions and trauma-informed approaches that can be taken to support not only the substance abuse treatment that occurs in the regional partnership grants, but also the interventions that are needed to build parenting capacities and the interventions that are needed to promote well-being and improve functioning for parents and for children. Next slide. The comprehensive support services for families affected by substance abuse and or HIV/AIDS is quite similar insofar as we are hoping that states will begin to think comprehensively about how to package a set of interventions that improve parenting capacities, social and emotional well-being, and address the substance abuse issues that are seen in this population. We really think that it is possible to think strategically with your partners and looking at the literature around what are the strategic interventions that are most likely to improve functioning. It's important, I think, to note with these two grant opportunities and one that I will talk about in a moment around supportive housing, about how important addressing the needs of parents are in this work. Sometimes I think when we talk about improving social and emotional well-being for children that people don't always hear that we are promoting social and emotional well-being and targeting parents for healing and recovery as well. And the discretionary grant opportunities that we have made available really do get at this issue of how do you promote social and emotional well-being within a family context. You'll note many of the interventions that we think actually improve functioning for children. Almost all of those interventions involve parents and or their caretakers in the healing and recovery process and identify opportunities for enhanced nurturing and enhanced parenting capacity. The initiative to improve access to needs-driven, evidence-based or evidence-informed mental health and behavioral health services in child welfare. We're really hoping that states will take advantage of this funding announcement insofar as it does a few really interesting things. It helps states to begin to organize its thinking around screening and assessment and aligning the service needs to, or service array to meet those identified needs so that you are really beginning to think strategically about what are the effective mental health and behavioral health services that we need to put in place to address the needs that are identified through our screening and assessment process. In addition, making sure the case planning, is like the Commissioner identified earlier, is trauma-informed, is meeting the needs that are identified, and that the service array is configured consistent with what you are finding. And then the last one that I want to highlight is the partnership to demonstrate effectiveness of supportive housing for families in the child welfare system. really what we are trying to do here is help states begin to think about a real prevention approach that allows for the identification of families early on when their housing needs are high and their risk for involvement in the child welfare system is high, and or they have become involved with the child welfare system. Thinking through what partnerships are necessary to provide not only the traditional child welfare supports, but really bringing housing to the table in a way that provides a more comprehensive array of services, that creates a case management approach that involves multiple partners to address the whole needs that this group of families bring to the table. And really, again, a core component around assessment of their needs so that the service array is coordinated and meets their needs. As I talked initially about the way that psychotropics fit into the overall trauma approach, I just want to make note here that you consistently hear a number of pieces of what we think is an overall approach. And this slide really, in an interesting way, looks at how trauma screening and assessment, evidence-based practices, the psychotropic medications, the funding announcements, and the waivers are all tributaries into the larger river of social and emotional well-being that we think leads to the much larger body of improved outcomes and improved functioning for children and families. And so we just want to make sure that as people hear any individual component, that they are recognizing, and we hope to explain how they are interrelated, how they connect to each other, why we are asking people to consider these as a comprehensive whole to achieve social and emotional well-being, and then how to get to improved outcomes, improved functioning. So rather than an approach that allows us to say that we've provided a service and therefore we've been successful, or for us to monitor that that service has been provided, to really begin to think about what will it take over the next 15 years to get to a place where we're showing that because of our intervention, because of the effective practice, or because of a demonstration grant that we've provided on the discretionary side, or because of the waiver demonstration, that those interventions have made a functional difference for children and families.
Thank you, Claire. We're going to spend the next 20 minutes or so hearing both about the role of Medicaid as well as the role of mental health from our partners that have joined us here today. And then we'll get to the question and answer portion of our afternoon. So I'm going to go ahead and hand it over to Jean Close to start off with the role of Medicaid.
Thank you, Sonali. Again, it's a pleasure to be here. About a year ago or so, Commissioner Samuels and his staff brought a number of federal agencies together to focus on the issue of psychotropic use in children in foster care. And the core group was the CMS, ACYF, SAMHSA, as well as a number of other federal agencies in that endeavor. And one thing I was struck when we launched that, or the beginning of our work together, was the personal commitment of everyone who was involved with that initiative. And it was striking because as compared to a number of other initiatives I've been involved with, as part of our regular work in working together with other agencies. I believe each of the organizations took and looked at what they were doing and tried to identify what are we doing personally that can be brought to bear on this issue. And it started to inform our plan going forward, looking at our vantage points and moving ahead with this. A memorandum was published with a complete listing of those activities going forward. But a couple of those that CMS was engaged with, and also it continues to be with our partners, surrounded an initiative to look at eligibility. What difference does it make, or what are the barriers of children moving in and out of foster care that we can identify and do something about? Are certain states doing this well, working with children moving in and out of the system, and can we disseminate those practices? We began to frame our actions according to our triple aim in our center. We try to use a framework to organize our work, and we're trying to think, what can we do for the individual children? What can we do for the whole population of children? And what can we do to ultimately lower costs and increase quality? So our activities began to focus on sort of the big picture as far as our population. Electronic health records were a big part of what the Affordable Care Act put forward to help providers to develop their infrastructure for communicating the care and the treatment of individuals within their care. In addition, we looked at drug utilization review. What are some of the best practices that our states are using, particularly as they surround the monitoring of medications for children in foster care, but as far as the larger population as well. Over the many months, we learned more about the issues surrounding psychotropic use. And again, much credit goes to ACYF for making some of the latest research available to us so that as we move forward with implementing some of these activities, that we could be informed about what is going to make a difference, what is the true problem. And we began to understand the role of the impact of trauma on children. And with that impact, how we move forward with some of our activities, both with our federal partners and also through Medicaid, in partnership with our states as well. And going forward, we thought that, are there some authorities available through the Affordable Care Act that would help promote and also address some of the issues, the core issues that were presented today? And we're actively looking at how can the new Health Homes Authority bring children and families together in an integrated situation where not only their primary care but also behavioral health needs are addressed comprehensively and as a family. We began to look at what kind of services is Medicaid reimbursing, and try to also to get an idea of what is effective and what is not so effective. What can we advise states would be the kinds of services that really would make a difference, that are the right services and would be provided at the right time to individuals. A key theme, and I'm also seeing it in the issues that were presented today, is the issue of screening. Through EPSDT, which is Medicaid's program for serving the health care needs of children, screening is a requirement for every child. And I'm also hearing through this initiative of looking at children who've been impacted by trauma, that screening is such an important component. So again, we're actively working to try to understand what are the best screens, how can these be integrated into current practice that states are currently using as well. So we have a lot of different missions here. But again, the common thread is that we're trying to serve children, particularly children, vulnerable children who are in the foster care system. I think that's what brings all of our agencies together in these efforts. It's going to be an ongoing activity that we're truly committed to. But I'd also advise, and I'm hoping that participating in this webinar are agencies that are actively pursuing their applications for some of these new grant opportunities or the Title IV waivers to contribute to your, continue your work. It's not easy to partner with the other organizations, the other entities. It's foreign territory, but again, the common thread is children who need additional services, who need access to the right services at the right time. So it may be, that may be the most difficult part of this whole piece, is trying to connect with your partners at the local level and moving forward. And as Commissioner Samuels mentioned, there is technical assistance available along the way to help make those important kinds of connections. I guess I'll go on to the next slide. That's it. That's it. Okay, great. Moving forward, again, just to summarize, I think improving access is an area that we really need some help with. You are the providers. You're in contact with the children, with the systems of care. To borrow your frame reference. And so we really need help. There is reimbursement available for many of these services through Medicaid, through other sources. We need to understand what a good benefit is, what really works. We really need to focus on identifying what are those outcomes that we're all seeking to achieve and actually making it happen. We have some excellent research available at this point, but going forward, the task is partnering with our agencies and Medicaid in actually making some of these best practices happen. And improving the quality as well. We can do a lot of work, but ultimately I think our goal is to improve the quality of care. One of our important partners in this endeavor is the mental health entities led by the Substance Abuse Mental Health Services Administration. I'd like to invite my colleague here, David Dvorny, in talking a little bit more about SAMHSA's work.
Great, thanks so much, Jean. I should say we coordinate the field. We do provide leadership, but the states play such a huge role in mental health as they do with Medicaid that we are there as a supportive function as well as trying to provide leadership and direction to the field. And I think where you left off is a great place for you to pick up, because in my talk I'm actually going to in my talk by discussing quality, and then move in a little bit to what SAMHSA is doing and some of our efforts to try and improve the quality of behavioral health service. The behavioral health, I'm talking about both mental health and substance use, which are both underneath SAMHSA's mission. So when I think of quality, the first thing I think of is workforce, because the behavioral health field, we are our instruments. Literally, it is our instruments that will help them reach where they need to be and address their behavioral health. Okay. All right. So it's important to realize that we have a very stretched workforce in the behavioral health system. This is a map from our colleagues at the Health Resources and Services Administration. And you can't see the detail on it, but the important part to realize is those little yellow spots you see on the map, those are the areas where we don't have a mental health service provider shortage. The rest of the area in that map is where we do. So there's 94 million Americans. Well, a lot of those are rural areas, so people are not evenly distributed across the country. But 94 million Americans live in areas designated as mental health professional shortage areas. And what that means is there are not professionals to provide services for 69 million of the people who live in those areas. That's the general population. That's the entire population in the U.S. It actually is worse for children and worse for populations who are at higher need for a variety of reasons. So that is actually maybe an undercharacteristic. This problem is bigger for the population that we're working with and discussing today. So I just want to really put home, workforce is very important. Fortunately, services are going to be hopefully expanding in 2014 with the Affordable Care Act. But that means the same workforce is going to have a broader mandate to provide services. So in all of our efforts, it's important that we think about workforce first. And any successful efforts will involve the training of the workforce, providing support to the workforce, and really focusing on implementation. So I just like to highlight that first of all. But there are a lot of bright spots which are going to help us meet these challenges. First, I'd like to talk about electronic health records. These are not just ways to improve the coordination of individual care and store information about people's services or the supports that they're receiving. They actually provide us with great opportunities to provide decision supports for clinicians and for professionals working with individuals. And they also provide the opportunity for us to look across systems and looking at data inside of systems to see what's really going on. And this is one of SAMHSA's key efforts around improving the quality of services. We are working with our partners at CMS, with the people in the downtown and at the Department of Health and Human Services and the Office of the Secretary and the Office of the National Coordinator to identify quality measures around behavioral health issues and get those moved into systems so we can better measure the quality and ensure the quality of behavioral health services being provided. But as I said when I started, there's a lot that we can do at the federal level, but there's a whole lot that can be done at the state level. Increasingly, states are moving to large contracts to provide state services, and this is under Medicaid, but it's also through their general funds and through funds they receive through a variety of block grants and other grant mechanisms. And in those contracts that they make with providers and groups of providers, they can really define what they're requiring as far as the quality of services and the types of services that are provided. So it's really important that we engage states, and I think it's just remarkable the leadership that we've seen from both the Administration for Children, Youth, and Families, and on Children, Youth, and Families, and the Centers for Medicare and Medicaid Services in that direction. So it's been great to have them as partners through this partnership. Health reform really does provide us with a great opportunity, and SAMHSA is trying to meet that challenge by defining what we call a good and modern service system. None of us really like that term, but it's stuck, so we're stuck with it. But it basically is a set of services that we think should be a part of a modern system for providing behavioral health services. And this includes a range of preventative services, treatment services, and recovery support services for people with behavioral health problems. And we put out initial definitions for some of these services, and we're working right now to provide more information about what are the evidence-based components of those services, what are the most effective aspects of them, so that we can inform decision-making leading up to 2014 and through waivers and block grants and other mechanisms. So that's a major part of the work we're doing around health reform. I'd also like to highlight two other aspects around health reform that are really important. There are 10 essential benefits that are going to be covered for populations who are getting expanded services as a result of the Affordable Care Act in 2014. And while these services have not yet been defined, so I'm not going to say we know exactly what they're going to look like, there is a requirement that the mental health and substance use be included within them according to the law. And one of the populations that's going to be receiving services as a result of the service expansion is youth who have exited the foster care system and who were in the foster care system for 6 months or more when they were younger. And so there's a huge opportunity to meet the needs of those youth and do service coordination on that end of the service spectrum, especially considering many behavioral health problems emerge in that 18 to 24 age range, and it's actually the peak age range for substance use. So there's a lot of opportunities to improve services for that population and through the Affordable Care Act. Another statistic I like to highlight is looking at coverage for parents. If this is what you see on the graph here, and this is very small, I apologize in the room, you probably can't read it, this is a graph looking at the level of coverage in 2008 for just basic insurance without getting into the specifics of what's covered. But I think the takeaway here is that 42% of parents of children in poverty, families in poverty, don't have insurance coverage. And 33% of children between 100% and 200% of the poverty line don't have insurance coverage. That's for health, and it's probably worse for behavioral health. So we're working with a lot of parents who don't have coverage for needed services. And this is a major risk factor for child maltreatment and for improving efforts to reunify families and create stable placement. So we really need to understand that this is a huge opportunity coming in 2014, not only to work with children, but also to engage parents and provide them with an increased range of services. So SAMHSA already is doing quite a bit of work to focus on these issues. We have 2 large block grants that we put out to states, one focused on mental health issues and one focused on substance abuse prevention and treatment. This last year, for the first time, we actually asked states to provide their responses to us in a combined application. We want to see increased coordination and the implementation of services underneath the block grants. We understand that people don't come to us in silos, so we should try and switch our funding streams so they don't go out in silos as well. So we're encouraging joint planning in that way. We have several individual programs also that are designed to improve the quality of services provided and improve infrastructure around those services. The first I'll talk about is what we call the Children's Mental Health Initiative. You may have heard of these grants, also known as the Systems of Care grants. Basically, what we're trying to do is to get communities, we've done this since 1991, to coordinate services, to create wraparound services that are family-focused and individually focused on the needs of youth so that they can decide the services that they need and to really get the support that they need. And traditionally, we've put these out to communities, but along with the state focus that I've mentioned, we've now moved to, last year we let out the grants to have a focus on statewide planning, and now we're moving into a phase where we're putting out statewide implementation grants to help really take the practices that were effective in the community level out to the state level around coordinating services for children with serious emotional disturbances. We have a similar focus in our assertive adolescent treatment and family treatment program, which is really focused on substance use treatment needs for adolescents. In that program, we have for the first time identified state coordinators across the country to focus state efforts on adolescent treatment of substance abuse issues. And so we are also trying to focus on the quality of services there. We have a burgeoning project actually to help focus on purchasing around those areas. Also, we have Project Launch, which is an early childhood program. It has a similar state focus, helping to coordinate services, and especially that program is focused on moving what we know about behavioral health into other systems, into primary care, into child care, into child welfare. And so we are really focused on trying to not just look at how we can improve services for children receiving treatment, but also what we can do around prevention and promotion in behavioral health as well. The final grant on this page that I'd really like to highlight, and it's really important for you, is the National Child Traumatic Stress Network. And I'm sure many of you are familiar with this grant program, but basically it is a provider-researcher partnership. And we've funded grantees all across the country. Some of them are research institutions with expertise in serving children who have experienced trauma, and some of them are practitioners who have experience working with that population as well. And basically, they've partnered together to create and then to implement and test and refine implementations for serving these children. They have a wealth of information around working with children who've experienced trauma. I saw them cited several times in earlier presentations that you've seen today. And they have a lot of information on their website, which is here at www.nctsn.org. So I would encourage all of you to go check that out. And actually, that's been a key part of our partnership so far between these three agencies represented here today. We've worked heavily to link National Child Traumatic Stress Network resources with other agency efforts, just like the Administration on Children, Youth, and Families Integrating Trauma and Child Welfare program. We have a number of partnerships that we're working on with the other agencies too that I think are really important. We're working to develop a high priority trauma goal around children and youth in the child welfare system who experience trauma. We're very happy to be working with the other agencies on that. The focus on psychotropic medications that you've heard about, we are definitely invested in, and SAMHSA is looking forward to the summit in August and bringing together state leadership from mental health, Medicaid, and child welfare to improve services and practices around psychotropic medications. We are bringing together an expert panel to focus on treatment or therapeutic foster care in order to understand what are the key components of that type of intervention, and what do we need to know to inform state-level purchasing and to inform practice around therapeutic or treatment foster care. SAMHSA has a number of ongoing partnerships with the Administration on Children, Youth, and Families and other agencies that are also important. We jointly operate the National Center on Substance Abuse and Child Welfare, which has a lot of information on children in the child welfare system who are in families that are affected by substance abuse, and also resources for serving the parents in those families, which is, I think, a great resource and a great ongoing partnership to support our work. And then also, we have a number of interagency programs which I think really can help support and guide our work across agencies, even broader than just those represented here at the table, including the Interagency Work Group on Youth Programs, which includes representatives from 14 departments, That's not just sub-agencies inside of HHS, but departments across the federal government. We have a lot of leadership from the Office of Child Abuse and Neglect. They bring together federal employees from across the government to focus on that issue through their interagency work group on child abuse and neglect. And then finally, there's a number of partnerships focused on early childhood. One especially, which has lasted since 2007, focused on staff-level partnerships around early childhood, but most recently the development of the Early Childhood Health and Development Coordinating Council at HHS, which is bringing together leadership from across the different HHS agencies to guide our work in early childhood. But with that, I will pass it over for questions.
Thank you so much, Jean and David. Thank you for walking us through the partnerships that we've forged, and thank you very much for being here for this portion of the town hall, where we're going to actually take questions and engage with the folks that have joined us here in person, as well as those who've joined us online. We'll do our best to work in any questions that folks can send us through the question pod. We will pause intermittently to incorporate some of those. But for folks who are here in the room, we've got a mic in the middle of the room to make it feel as much like a town hall as possible. And we welcome you to walk right up and engage in a discussion with us. I can go ahead and start with a question that looks like it came in online. The question is, will the contract, parentheses, waiver, accept community-defined practices versus evidence-based programs?
I think ultimately what programs are included in waivers are really a decision that the state has to make. And so states will be working with their provider community, including those that are community-based agencies, to determine what's the right mix of services to be included in the waiver. I would only make 2 points. Specifically, one was that we highlighted evidence-based practices, not to suggest that there isn't important work going on at the community level. But as we looked at prior waiver proposals, there was a limited amount of attention given to the quality of the services under those waiver announcements, and instead they focused on how best to coordinate or connect dots to one another. And we're simply raising the question of, are we connecting dots that are effective dots to one another versus simply connecting services that may not actually be contributing to a child-level improvement in functioning or a family-level improvement in parenting and capacity. So we elevate it for that reason. And second, we leave open the language of evidence-informed so that states can define those as they will. Again, there's no requirement that a state has to submit a plan that has an evidence-based or evidence-informed strategy. We simply think by having states look at the evidence and make a determination about which of the services they want to connect directly to their waiver, they increase the likelihood that they'll produce child and family level outcomes. But again, at the end of the day, the decision about what services to include, or even whether to include services in a waiver proposal, is one that states will actually make.
For those of you coming up to the mic, I'd just like to ask if you could give your name and your organization. That would be great. Thank you, sir.
Hi, I'm Andre Wade, National Alliance to End Homelessness. Just had a question for Commissioner Samuels. I wonder if there's room for, in the waivers for child welfare agencies to target unaccompanied minors that might access the runaway and homeless youth programs as a way on a prevention end to work with the families with family intervention and strengthen the family so that it could prevent that minor for coming into the foster care system.
I don't think that that's a named population within the waiver itself. However, I think ultimately states decide the best venue for serving unaccompanied minors. The vast majority of them are served through another federal program. but there's a small number of states that may choose to serve some unaccompanied minors through the foster care system, but that's really a technical question. So the most straightforward answer to your question is I don't know that the waiver envisioned unaccompanied minors as a target population, but I think states would have to look at their current definitions and decide whether they are currently eligible for services under child welfare, and if they are, then the child welfare system could certainly serve them through the waivers. But I don't know, I don't recall that they are at all mentioned as a target for waivers themselves. That would have to be one of those technical questions that states would have to look more closely at, and we certainly would provide whatever technical assistance states needed in order to make that determination.
Okay, we've got questions rolling in from online. We've got about 6 questions that I can go through, but that's just a challenge to those of you in the room to come on up and ask your questions as well as anyone here on the panel. So the next question we have that came in through the online portal is, are the waivers also open to tribes, or do they have to partner with a state or county?
Sure. The waivers contemplate those agencies that are considered a Title IV agency. So those would be entities that are already operating a Title IV program. So as we sit here today, that would apply to all of the states, and we just have one newly awarded authority to a tribe in Port Gamble to operate a 4E program. So Port Gamble would be eligible in theory to come in for a waiver. All other states that would participate in the waiver would have to do so through their relationships with the states. So we know that there are over 70 tribes that have agreements with states to operate some portion of Title IV-B or Title IV-E, and were any of those states to come in for a waiver, those states could certainly include the work that the tribes are already doing in the context of that waiver proposal, but only Port Gamble would be eligible for coming in independent of a state for the purposes of pursuing a waiver.
Okay, our next online question is there room in waiver proposals for workforce quality improvement, and is this a federal priority?
We certainly think that improving the skill set for frontline workers is an important component to getting to better outcomes for the children and families that we serve. States already are eligible for training dollars through Title IV-E for the purposes of frontline staff. While the funding eligibility there limits those funds to training issues around policies or understanding the populations that child welfare is serving, certainly any additional training that states wanted to do in those categories, they could do using Title IV-E dollars. There's a limitation, however, to training dollars as it relates to specifically training staff on a particular intervention that they would then execute. That's not an eligible activity, Title IV waiver training dollars, so states would not be able to do that work. But if states wanted to train their workers on aspects of trauma, if they wanted to educate them about aspects of evidence-based practices that would make them better caseworkers or social workers, it's certainly feasible under Title IV-E that they could do that. And in essence, they could do that without a waiver. So states could do that part today. But we certainly would encourage states to give that consideration under the context of a waiver, because we think frontline workers play a critical role in getting to better outcomes for children and families that we serve. And if we want to make our service system more sophisticated and more nuanced to address the particular needs that children and families have and not the generic approach to that, we think that there's a real benefit to considering allocating some of your waiver activities specifically to training frontline staff. And I would only note that it is equally important
that folks like the courts have access to that training, or some of the CASA or guardian ad litems. And so we think that given the broader authority under fostering connections around who is eligible for training dollars, we think all of those entities would benefit from an overall upgrade of their knowledge and capacity as they move forward with implementing a waiver proposal.
We have about 20 more minutes for this discussion portion, so I welcome you all to think about any questions you may have within that time frame. Our next online question, I think we can begin a response from our partner here from SAMHSA and then open it up to anybody else on the panel. But the question gets to mental health providers. So the question is, good mental health providers practice in areas where they receive the most compensation for their services. Often rural areas are left out because of poverty. How can this be addressed in the grant?
Well, I think one good thing about our grants is that they are pretty well distributed across the country. They do focus on populations which are at higher risk for a variety of reasons, including access. And so especially those individual grants that I talked about, System of Care Grant, the Adolescent Treatment Grant, the Project Launch, and the National Child Traumatic Stress Network, they do have grant sites which are located in rural areas. And then, of course, the block grants are distributed by states, and they are really designed to fit into systems where there are gaps in services around the rest of the infrastructure in our country, those block grants. And so I think as far as our grant funds are concerned, they can actually be used to kind of augment services or to attract people to provide services in rural areas. That being said, I'm not trying to discount at all the huge shortage of workforce that we have in rural areas. There are some things that we can do, like telemedicine or telebehavioral health, to augment the resources and information that providers have in rural areas, but there really are core shortages where there are clinicians. They often don't have as high-quality training in rural areas. And so I wouldn't minimize the needs in those areas. I will say that there are different ways you can look at services, looking at services that have been adapted to meet the specific needs of populations in rural areas, and looking at different kinds of provider models, doing interesting things in primary care and with community organizations or the organizations that do exist in rural areas are other ways to look at trying to provide services, but I don't want to minimize the challenges that do exist in that area.
Thank you. It looks like we have a question from the in-person audience.
Yes, thank you, Sonali. Miriam Rollin with Fight Crime Invest in Kids. And I was very interested, Commissioner Samuels, in what you said about, in the context of solution-based casework regarding Medicaid having the ability to make some of the evidence-based strategies sustainable in the long term. And I'm interested both in your thoughts and also, Ms. Close, in your thoughts as well, about ways that Medicaid can be tweaked through program instructions and non-statutory, non-regulatory approaches that are very doable by the agency to make sure that we're eliminating barriers to those evidence-based approaches actually being Medicaid reimbursable for kids who need them. So things like, family treatments, which have been found to be very efficacious through randomized control trials, would actually be very difficult to be reimbursed for Medicaid because the parent part of it can't be reimbursed, because if it's a multi-systemic approach, which all of the evidence-based ones are, you can't actually pay for things like casework that might be beyond some of the direct services that are medical provider services. I'm thinking of multi-systemic therapy, functional family therapy, some of the therapies that have been developed that are very effective, but really it's a number of the pieces, whether it's transportation, casework, full family services, just don't fit in nicely to the Medicaid reimbursement model, but that do have medical outcomes that are very positive.
I will answer the first part of the question and then hand it over to Jean. I think the important point that I would make here, Jean, is all of the opportunities that I've described so far
are in the category of not requiring a tweak. So what we're saying is that as we sit here today, Medicaid is committed to bringing forward any support they can provide under the existing authority, so that anything beyond that authority obviously has an internal process that I'll let them describe, but more importantly, there aren't many tweaks theoretically that are going to happen before states are able to take advantage of the immediate waiver opportunities that we have. So I want to be careful that that you don't have the impression that I'm over-promising what Medicaid to do. What I'm promising today is that Medicaid is prepared to help in all the places where they already have authority.
You've asked a very important question, and I'd like to address it from right now, in 2012 versus 2014. I think the answer would be different. You're looking at, I believe your question was focused on approaches that involve a whole family. And perhaps a whole family is not a Medicaid eligible. It does not include all members that are Medicaid eligible, which is a primary consideration for reimbursement from Medicaid for services. That said, in 2012, this year, many of the services could be brought to bear for the children involved. But it will depend on what states provide. Medicaid is a federal-state partnership and very dependent on a particular state. So I think it's key to understanding, well, what does our state reimburse through Medicaid? Is it the primary key? And looking at the various authorities that services are reimbursed under, whether it would be the state plan or through Medicaid waiver programs to make things more complex here, which may have additional flexibilities beyond the core Medicaid services. We're also looking at the authorities such as health homes and other similar models where you're looking at one entity that's providing all the care that an individual may need. I think this is a great opportunity for family members to be served as well, because certainly an individual child would be served, but part of the care that would be brought to bear would be to engage other family members as part of that health home approach. And so that is currently available now, and it is a new authority. And I believe there's one state that's looking at incorporating as a group with chronic conditions those with behavioral health needs. So it'd be children as well as adults would be in that group. Looking forward to 2014, there will be a new group that's going to be eligible for Medicaid. It's an adult group, which would encompass many of those who would be considered parents, family members, or those associated with the children that we're most concerned about. And in their own right would be Medicaid eligible and entitled to a variety of services. Again, that would be included and differ by states. I think that's another opportunity to provide a more comprehensive approach to serving youth in a family situation. Third suggestion is we talked a lot today about partnerships, and that those are true partnerships where both partners are bringing something to the table. And I think, again, these the waiver programs and the grant programs that we're talking about today are great ways for both partners to sit at the table and identify, well, we can cover this under Medicaid, but Medicaid doesn't cover this, so maybe the other partner can cover the services that are not. And in both respects, there's something to be gained for both systems to work together, again, and to move forward the model you described today.
Okay, we've got a question here that speaks to something the Commissioner suggested. The question starts off with, the Commissioner suggested some advancements in the area of trauma-informed investigations. many states are implementing differential response systems, which result in many families, often those that fall in the neglect category, to receive assessments rather than investigations where there is no substantiated report of maltreatment. Do you see possibilities for taking a trauma-informed lens and applying it to the assessment pathway?
So I think that the assessment pathway is a great opportunity to specifically look at trauma screening and assessment as a vehicle for better understanding what services and supports would have the greatest impact on reducing family dysfunction and increasing the likelihood that there would be no further referrals to the foster care system. So I think looking at screening and assessment, particularly around trauma issues in the differential response environment, is an important step. In the differential response setting, however, states could decide tomorrow to use a different screening instrument than the ones they're using. So states wouldn't necessarily need waiver authority to move in the direction that the question suggested. And there are some screening instruments that are short and reasonably easy for staff to be trained on completing, and would be that in that first layer of the trauma strategy, which was screen and see if there are any major indicators, and then if there are, you can do a further assessment. But there are certainly screening instruments currently available that look at issues of trauma and could inform the work that is done in differential response. And I think in the bigger picture, I think the distinction between what I was suggesting in terms of focusing on neglect and the focus that differential response has on neglect is that, as states try to build systems where they try to leverage the concept that the added authority that the waivers provide them is the potential to serve some families who would otherwise enter the foster care system, to serve them outside of the out-of-home care environment. And I think that's where I'm referring to the families with a substantiated case of neglect. Those are families that are at high risk of entering, but some of them may be very appropriate for serving outside of the out-of-home care environment with the additional resources that could come from a waiver. So as you can imagine, right, when a child moves from in-home services to out-of-home services, the state becomes responsible for covering the daily costs associated with providing safety and care for that child, sometimes described as they're responsible for the board and maintenance costs associated with maintaining a child in out-of-home care. That's a fairly high expenditure. They're paying for a foster parent, for a group home, for a residential provider to provide that care and support. In a scenario where they could use their waiver, states might decide that that same money that they had originally dedicated to the in-home population could be used in the that they had originally dedicated for the out-of-home care population could instead be transitioned into a program that is inserted in the home. And by doing so, they can put more services in the home than they could have otherwise in the past, because now they have that federal contribution that they could choose. And typically what states would say is they think in many instances, if they had that federal contribution and they could use it in-home services, they think they could get better results, more services, more appropriate services. So this would be an instance where the waivers would be the vehicle for doing that. And I'm just targeting that neglect population because they're at high risk of entering the out-of-home care environment. And if states had these additional resources, intervened effectively, addressed issues of trauma, were more comprehensive, they could meet the needs of the family and the child, potentially reduce the likelihood that that child ever enters out-of-home care, gets a better outcome for the child and the family,
and in the long term probably saves money for the state government and the federal government. Again, while the intent is not to save money, the benefit of the waiver is that states can flexibly use those dollars to focus on getting better results. And if that's done more effectively in a home environment, then this is an opportunity for states to be able to move in that direction and to have that federal support as they move in that direction. I'd make one other point, that in all of these waiver opportunities, if states are going to serve risky families in the home, they need the partnership of the courts and they need the partnerships of the General Assembly, because that's got to be a collective decision that says that as a state, we are prepared to incur a little more risk in return for the potential for getting a greater benefit by serving a family in the home. If a state were to decide that the risk was too great to serve a family in the home, again, they could still focus their waiver on out-of-home services. I'm simply making the point, if states want to try to serve more families in their home setting, I think they ought to do that with the court. They ought to do that with the General Assembly so everybody collectively knows the reason why they're doing it, the criteria they're going to use for what they do, and ultimately they're all going to collectively be willing to own the overall success, or where there's risk, they're willing to share that risk for the long-term benefit of getting services to kids and families with the potential of not breaking them apart and bringing them into out-of-home care. So there's a decision to be made there at the state level, but I think it's got to be a collective commitment so that the Child Welfare Agency can go forward with the confidence that they have the courts and the General Assembly with them as they implement a waiver initiative.
Okay, we have time for one more question, and it looks like we've got an in-person question here.
Hi, I'm John Kelly with the Chronicle of Social Change. Brian, you mentioned in the guidelines, pay for success ideas, social impact bonds. I'm wondering if you have any in mind, child welfare outcomes that sort of lend themselves to that concept, and if you guys are aware of anybody that's actually pulled that off or tried it.
Sure. Social impact bonds, it has been a real interest on the part of the Obama administration almost from day one. Social impact bonds are a vehicle for the private sector to make investments in public sector activities where the private investors anticipate that public monies could be saved if the right set of interventions were used in a timely fashion. Usually what people think about is those interventions as having higher upfront costs that sometimes public systems aren't willing to incur. But if the private sector were to incur those upfront costs, but believe that in the end they produce better results that saves public dollars, then that would be the environment where a social impact bond might make sense. So in child welfare, I think it's really a question of taking a really close look at all of the available evidence-based practices and asking the question, are there some of these practices that have a reliable outcome that they will produce, but have a substantial implementation cost that the private sector would be willing to invest in, really to drive the public system towards seeing that the upfront cost has a longer-term benefit that the public over time should come to appreciate and should come to an understanding that all public funds ought to be considered on a longer time scan than sometimes they are. So that's the starting point for folks that don't know the issue. Now, there have been a small number of private foundations that have specifically expressed interest in pursuing these social impact bonds in a child welfare context. And so we included the language of pay for success in the waiver announcement so that states that are interested in going in this direction could be connected with some of the foundations that have expressed an interest in going in this direction. I will leave it to those foundations to make public who they are and under what circumstances they would agree to do this. But we wanted to make sure that the waiver announcement provided an opportunity for states to come forward that would be interested in pursuing a social impact bond strategy, and that philanthropic organizations that were interested could come forward, and that we would play the role of matchmaker of sorts, but to also let states know that they could use the waiver itself as a means of providing a platform for those kinds of social impact bonds being implemented. So I'm reticent to give a specific name of a foundation or a state that expressed an interest, but I can say that over the last 12 months, we have seen considerable interest on the part of states and some foundations to do this work, and we wanted to make sure that within the waiver demonstration opportunities, there was a means for doing that. So that's the best answer I could give in this setting. Thanks.
Okay, thank you very much. We're just at the 5 o'clock hour here. I appreciate that we've got a few outstanding questions that came in from online, and we'll follow up with folks accordingly. And I also want to just, as we wrap up, remind folks that this town hall has been recorded, and it will be available online for folks to access in the future. Thank you for coming, and I'll just, we'll close with any last words from Commissioner Samuels.
So again, I want to thank people for participating. I also want to thank our partners, SAMHSA and Medicaid, CMS, excuse me, for being here today. We have a great working relationship with them. We want to model for states the kind of partnership that we have had here, because ultimately we think being able to bring the state Medicaid agency, the mental health agency, and the child welfare agency together in a waiver is a great opportunity. It has the potential for being transformative for the child welfare system. It has the potential for creating efficiencies at the state level. And most importantly, it has the potential for really changing the way the child welfare system serves all of the children and families that it comes into contact with. So I want to thank them. You know, and then I want to just close by saying that, again, you know, we use the trauma-focused lens not to suggest that that is the only approach to waivers. We really wanted to use the trauma-focused lens simply to say, what does the waiver have as a potential for changing the way the system operated? And so we wanted to highlight some of the national efforts that have already occurred around the child traumatic, highlight the work that's already been done around screening and assessment for trauma, some of the work that's been done around investigations and interventions, again, because we see that putting those pieces together in one place could be really powerful and have a really transformative effect on child welfare. But at the end of the day, we want to see innovation across child welfare, and we welcome any state that brings forward a strategy that pushes innovation, that pushes outcomes, and ultimately tries to build a system that is coherent and supports families at whatever the most appropriate level of support is needed for them to succeed. So thanks again, and we'll see you down the road.
Thank you for participating in today's conference call. You may disconnect at this time.